Good afternoon, everybody, and welcome back to Prevention Works Live. So this is our exciting series of webinars and podcasts with some of Australia's leaders in public health who are talking to us about their work and how they've been creating change for prevention and for the prevention of chronic disease. I'd like to begin today's session by acknowledging the traditional custodians of the land on which I sit, the Gadigal people of the Eora Nation. I also acknowledge the traditional custodians of all the various lands from which you may be joining this event, and pay my respects to elders past, present and emerging, and acknowledge all Aboriginal and Torres Strait Islander people joining this event today. So my name is Lucy Ryde-Chetnick, and I'm the co-director of the Australian Prevention Partnership Centre, a role that I'm happy to share with my fellow professor and co-director, Andrew Wilson. So I just wanted to say a little bit about the Prevention Centre. It's a national partnership, and it includes researchers and policymakers and practitioners who collaborate to find innovative solutions to help prevent our growing burden of chronic disease. So by that, of course, we mean conditions like diabetes or heart disease, cancer or poor mental health, conditions that cause ongoing illness, disability and sometimes early death. So the role of the Prevention Centre is to support research and its translation through innovative science communications and evidence-informed policy and practice. And our role is also to build and support the next generation of leaders in prevention, both in research, policy and practice. I just want to thank our funding partners. The work is funded through a pooled fund with 8 partner agencies, so the National Health Medical Research Council, Commonwealth Department of Health, New South Wales, ACT, Tasmanian Departments of Health, Wellbeing SA, Cancer Council and Vic Health, and we're administered by the Sachs Institute. So Prevention Works Live. These webinars aim to produce opportunities for you to hear directly from some of Australia's leading prevention innovators. So people who've been successful in translating research and changing systems that supports real impacts on health and well-being. Those of us working in prevention focus on all different parts of the bigger system that impact on health. So whether that might be health services or housing, food systems, transport systems, economic or political systems, or our natural environment. And so we want to provide an opportunity into some of the behind-the-scenes thinking and the challenges and solutions that our speakers have identified and overcome. And the really interesting insights that you don't usually see in a scientific paper or conference presentation. So today we're really fortunate to welcome Professor Tarun Weeramanthri. Tarun is the president of the Public Health Association of Australia, so of course would be known to many of you. He's also an adjunct professor at the School of Population and Global Health at the University of Western Australia. Tarun has had an amazingly diverse and impactful career and has successfully guided government policies and on-the-ground practice in an impressive range of topics, including chronic disease prevention, environmental health, climate change, and health sector responses to the COVID-19 pandemic. So just as a bit of background, Tarun is a medical specialist in internal medicine and public health, and he also completed a PhD in social medicine. And I think you can really see in his work and the writing that combination of scientific rigor, philosophical depth, and a humanities aesthetic. Many of us enjoyed his Douglas Gordon oration at the closing event of the Public Health Association's Preventive Health Conference a couple of years ago, titled Public Health in an Open Society, How Society and Language Shape Prevention. And if you're interested in reading that, it's actually available online through the Australian New Zealand Journal of Public Health. So Tarun's works included working in medicine and public health research in the Northern Territory. He's also been a Chief Health Officer in the Northern Territory and in WA, where he was Chief Health Officer for 10 years from 2008 to 2018. And he oversaw the final introduction of the Western Australia's Public Health Act in 2016. Tarun was also awarded the Sydney Sachs Medal by the Public Health Association for his lifelong contribution to public health in Australia. Many of you may also know Tarun from his more recent year-long statutory inquiry into the impacts of climate change on health in WA. It was the first inquiry that was initiated through the powers of the new Public Health Act and has been released by the WA government at the end of last year. And more recently, Tarun has also been working with governments in WA, Victoria, South Australia as an advisor on the COVID-19 response, and also with the Commonwealth Government on national contact tracing review, and has recently conducted an independent review of hotel quarantine arrangements in WA. So as you can hear, there's much to cover, and he really has got expertise across a broad range of topics. So I'm really excited to have the opportunity to hear from Tarun directly about how he's managed to have so much success in setting agendas and creating change across so many different important issues in Australian public health. So just a bit about the format for today. We're going to start with a presentation from Tarun, who'll speak probably for about 20 minutes, and it'll be followed by a question and answer conversation where we'll also be joined by Catherine Cullerton. And all of you listening, of course, will also be invited to contribute your own questions. So before we hand over to Tarun, I just want to quickly introduce Catherine. Dr. Catherine Cullerton is a senior lecturer in the Global Health and Health Promotion within the School of Public Health at the University of Queensland. She is one of our investigators with the Prevention Centre, and her interests include food systems, food and policy, food and nutrient policy, and how they're developed and what's the role of the food industry. Catherine's also really interested in that interplay between the science and the politics of public health. So we thought she'd be the perfect person to join us today in talking to Tarun, who's been such a skilled negotiator across a number of politically sensitive terrains. So just for the Q&A session, you'll be able to contribute questions by clicking on the blue hand icon in the top right-hand corner of your screen, and we'll try and incorporate as many of your questions as possible into the Q&A session and the conversation. Tarun isn't planning to use slides, but while he's speaking, you should be able to change the size of his screen by turning on and off the full screen format. So with those introductions, I'd like to hand over to Tarun and welcome you to come and speak to us today. So thanks, Tarun.
Thanks, Lucy. Thanks, Catherine. Really looking forward to this conversation. Thanks everyone who's dialed in. You know, when you put a career together in kind of one of those short bio things, it all appears kind of very neat and tidy, but it isn't. And for me, it's been a constant struggle to work out what the right questions are, how you can affect change the best you can as a person in a system. And I still feel the same excitement about working in public health as I did when I was in my 20s and 30s. And I think a career in public health is really a career in life. I mean, there's almost nothing in one's life that you can't learn from and bring to public health, and there's so much you can just learn from public health that you can then take to life. It's an incredible privilege. So that's the first point I'd make is it is a struggle. The second point is I've worked in lots of situations with limited resources, and lack of resources can be an advantage and drive innovation. So I'd say that to all of you. You may not be controlling, a lot of people, a lot of money, a lot of anything, but you may be somewhere in our public system. And I would like to say to you, you can make a difference. And there will be a difference that only you can make as well. So often I think about, we've all got our role, but we've all got our own unique role. And there's some things Lucy can do that Catherine can't do, and Catherine can do that I can't do it. It goes for all of us as professionals. There's something unique that only we can do, whether we're working at a local level, a state level or a national level or whatever, research policy. The next point I'd make is that pretty much everything you think about bureaucracy, I'd like to just reflect a little bit working in the public sector, is probably either wrong or only half right. Working in the public sector can be, has been for me, and I'm not here anymore, an enormous privilege. I really love being a public servant, and I'll say that, and I used to raise a few eyebrows by saying that. It can be the most innovative, creative context in which to work. And I'm going to go back to the late 90s, and I had a choice to make in my mid-30s when I finished my PhD in social medicine, whether to kind of go into an academic career or go and work in the public sector, in the health department. And I did choose the latter because it suited me better, my own personal kind of style, but also because I felt I could drive a lot of change or be part of a lot of change in the public sector quicker than in academia. That would be fair assessment that I made at that time. And I'm not saying that's the same for everybody. see that working in the sector as an opportunity to drive change, not as an opportunity to kind of push bits of paper around. Now, getting to that notion of pushing bits of paper around, people, I think, fundamentally understand the nature of public health work. We're a knowledge industry, and so we're privileged to be paid to think and do and, you know, interact with other people. We're not being paid to to do anything other than that. So when we do meetings or when we talk to each other, that's our work. And so a lot of what you have to do is take a different approach to the knowledge work we do, whether that's having a couple of, you know, a casual conversation with someone over a photocopier, or a formal meeting, or writing papers, or, you know, whatever it is. That's all our work. You have to enjoy every bit of it. So I'd say to you, one of the defining things about creating change in a knowledge industry is, you know, you have to enjoy meetings. You have to see them as social interactions. You have to be observant of what's going on. So we can come back to some of those kind of management type things in the public sector later. But to go back and talk about what about chronic disease prevention. So in the mid-90s, I just finished my research in Aboriginal health at the Menzies School of Health Research in Darwin. The previous, there was a position in Communicable Disease Control Directorate in the Northern Territory, which up until that point had focused only on communicable diseases. There was a growing understanding there was this burden of non-communicable diseases in the Northern Territory, so what we now call chronic disease. And it was particularly affecting the Aboriginal population, and it was being manifest by rising rates of diabetes and particularly renal disease. And more people were going on to renal dialysis, particularly Aboriginal people in the Northern Territory. And it was becoming a problem for both Territory Health Services, but also the whole NT government, because the costs of renal dialysis were going off the scale. So that was the context to create a new position, a single position, in what was wholly a communicable disease control directorate for non-communicable disease. So I took on that position as community physician, that's what it was called. And I had one resource, which was a person I could work with, and we had to decide what to do with that. And we just kind of took it on. And obviously there were other people who were doing related things across the department, but no one with this specific focus on chronic disease policy at the time. So we said we'd try and work in chronic disease and injury prevention. I won't talk about injury prevention bits, but we can come back to that. But that was really interesting learning as well, because no one was doing injury prevention policy in February, and I thought, well, we'll do it. No one else is doing it, we'll do it. And we'll network in with the rest of the country. But the major focus was on non-communicable diseases. And the thing we did first was set up what we called a chronic disease network. So this is where a lack of resources drives innovation. So if you don't have a lot of resources, what we did was try and tap into a whole lot of other resources that were on the ground that may not be calling themselves chronic disease, but which were dealing with different aspects, whether it was diabetes or renal disease or heart disease or health promotion or whatever it was. And we established that network, and we had four aims for it. We had 4 C's: communication, collaboration, coordination, and collective memory. And I remember the collective memory bit was the bit I cared most about. And the reason was, it says something. It says, we need to remember what we're doing because this is going to go on for a long time. Yep. So there has to be a process, a system to remember what we're doing, what worked, what didn't work. The second thing is it's collective, meaning no one person has the full understanding of this. And so it's got to be all of our views on chronic disease are partial. And also it recognises that there will be turnover over time. anyway, the Chronic Disease Network, which we set up and it had its first meeting in 1997 from memory, it's still going. So till 2021, it still has annual meetings. It's still the vehicle for chronic disease partnerships in the territory. So it started off with that one person. I think there's still a network project officer. It's still going, and it's still an essential part of the fabric. Some months after that, the Chief Health Officer came to me, who was Shirley Hendy, and said, look, it's great you've started. We've got a problem. Treasury are coming to us, and they're saying that this is going to drive the NT bankrupt, the renal dialysis costs. Not quite as dramatic as that, but kind of close. It was, escalating renal dialysis costs, and it was becoming a matter not just for health, but for Treasury. What are we going to, what should we do? And she was the one who said, it would be great if we didn't just have a renal dialysis strategy. We all know, because we're public health people, that this has got, a range of determinants underneath, which also affects a range of other diseases, not just renal disease. Could we not have an integrated approach as opposed to a renal specific approach? And then there was a group of us which she kind of allowed to develop what became the Northern Territory Preventable Chronic Diseases Strategy. And I pay tribute to all the people who worked together on this, and particularly Christine Connors, who was a district medical officer at the time. I can't remember her. And Christine is still part of that even to today. So that's, 25 years. So Christine's the longest torchbearer in this. But there have been many people who have contributed many things over now many years. And the approach was to first of all make it integrated, covering multiple diseases. Secondly, making it not just about the end point, but about the continuum of care. So prevention, early detection, management, rehabilitation. And to make it kind of simple and whole of life. So at the time, there's quite a lot of theory around life course approach. I'm not sure people kind of can cast their memories back to the Barker hypothesis and the life course approach. There were textbooks coming out, and that was the kind of buzzword at the time, and the impact of low birth weight on subsequent development of adult chronic disease, etc. That was all in its kind of nascence in the 90s. And we did pick up on this theory and thought this is important to kind of reflect in how we cobble together an integrated policy. So we made it from birth to old age. And then we had specific things that we could do in each of the periods of life. And we called it eventually best buys in chronic disease arranged across the life course. And those things are still the same thing we talk about now. One of the key things which we felt was important was developing an evidence base to sit behind the policy. So as a kind of someone who's come out of academia, I was a community physician, got together with community pediatrician, Karen Edmond, and we took the kind of carriage of the writing of an evidence base that kind of pulled together all the theoretical literature, not in that kind of systematic review fashion, but as best we could as people who kind of knew the literature. And not many people would ever have read that evidence base, but it was very much welcomed that the policy had an evidence base. So part of the trick about public policy is you have to realize that most people don't read the documents, right? So there's a kind of strategic intent of the documents that's beyond the words. And one of the comments when we put the chronic disease strategy to Parliament and it got bipartisan support was it was so nice not getting a glossy document, because basically we had typed it up in our offices, over the weeks beforehand and just sent it in. And I had no idea at the time around, proper structure of stuff. So we had an evidence base, and a policy document, and it was kind of 2-word document. And so we just kind of printed it out, stapled it together, and gave it to Parliament. And it kind of flew through because it was generally quite simple. cut me if I'm going on too long, Lucy. One of the keys about the simplicity I remember was I came up with a 10-point plan. And I was very, very happy with the 10-point plan because it was very comprehensive. And I presented it to my much more senior colleagues in the health bureaucracy. And there was someone who's probably younger than I am now, who I thought was very old at the time. And he said, Tarun, my young fella, it's all very clever, but it's not simple enough. Go away and make it 3 points. I hated him. I really did. I really hated him because he had completely not engaged with my brilliant work. But we did it. And from that day on to this, I've used his 3-point plan. So pretty much nothing I do, nothing I structure from then to now has not been in 3 points. And the key about 3 points is that each point can have 3 points, right? If you do prevention, early detection, best practice management, you can then have 3 points of prevention, 3 points, and 3 points. And you end up with 9 points. So simplicity is key, evidence is key. We didn't have any new resources at the beginning, but the idea was if you produce a good document, resources will follow. If you produce a good policy. So we managed to energize people. We had the chronic disease network going. We had good stuff in there. It was an approach that attracted bipartisan support, and money flowed subsequently. I had the nice privilege of helping Nous Consulting last year to do a review of the strategy from 2010 to 2020. So it continues to be part of the NT policy landscape. And I just helped them with a bit of public health stuff, so Nous did the consulting, but also looking forward to what it should look like in the next 10 years, from 2020 to 2030. And I have to say that the strengths of the strategy remain the strengths of the strategy that we set up in the late 90s, so the weaknesses remain. And it was always more quicker and easier because to get the change in the clinical practice, best practice management side, the social determinants, the prevention side, the non-health side, the broader partnerships you need, that still remains a relative weakness 20 odd years later. Despite everyone's best effort, despite the best words you can think of in terms of understanding the importance of that, and if anyone understands the importance of that, it's people working in Aboriginal health in Northern Territory. The other thing we did with the strategy was make sure it wasn't just about Aboriginal health, it was about everyone in the Territory. And that, I think, is also important to its longevity, so that chronic disease, not just Aboriginal or Aboriginal people in the Northern Territory, but also affects everyone in the Northern Territory. So I'm going to wind this off now. So with a 20-year perspective, it's nice to look back to something you did with a lot of energy in your younger life, acknowledging that many people had a role in this. I think that it is important. I had a bit of an atheoretical approach or an abureaucratic approach at that time. I had come out of research. I didn't really understand the bureaucracy. We put this stuff together. It got a lot of nice reaction. But I remember afterwards someone coming to me and saying, a colleague called Louis, I think it's work to make sure this is sustained over time. And I remember saying to Louis something like, well, we've done without a strategic framework so far, and I'm sure we can continue to. It was the least thing on my, and I kind of played it down, right? And it was a mistake. It was a big mistake. And eventually, I think after I left the Territory, etc., they did get a strategic framework, and it was important, and there was a whole lot of bureaucracy which I didn't understand at the time, which would have helped in the sustainability. But we all have our weaknesses, and we do need to listen to others with different expertise. So words policy has to be good enough for action. It doesn't have to be perfect. And even if the words are perfect, it doesn't guarantee the translation into action. So we just, in this, in a philosophical sense, what we continue to do is act in the world. We continue to have ideas in our head. We continue to then use that to drive change in the world. And then what we see comes back to us, and then we use that to modify both our actions, but also our ideas about what works because of what we've seen. So my basic philosophy is act in the world and see what happens, and then act again. Thanks, Lucy.
Wonderful. Thank you, Tarun. It's great to hear that story. And one thing actually that does come to mind first is, even though it was incredibly successful and effective, would you do it differently if you were going to do it now? If you were asked to help develop a chronic disease prevention strategy, would you take the same approach? Or if you would do something differently, what would that be?
The thing I would do differently, it's always everything's a trade-off. The thing I would do differently is see if we could have expanded the ownership of the strategy beyond the NT Health Department in the first instance. It clearly had a lot of resonance with the Aboriginal community-controlled health sector, but because it came out, even though it had bipartisan support as an anti-government strategy, it took a while to lose that mark. And even though the Aboriginal community-controlled health sector in the Territory has been at the forefront of action on chronic disease, for decades, and still is, probably the ownership of that strategy still feels a bit like it's anti-government. And so it didn't quite get the ownership across government and non-government. What it did get was an ownership with the non-government organisations, because as part of the Chronic Diseases Network, we brought in Diabetes Australia and Heart Foundation and the kidney NGOs and others, and they became an essential ingredient to the network and the strategy. But what we didn't get as strongly was the engagement with the Aboriginal community control sector at that time, though subsequently I think that's been achieved to a greater degree, but not still seen as, it's still seen a bit as an anti-government thing.
So I just wanted to invite the audience to also start posting questions if you have any questions, and Catherine and I will take turns to incorporate them into our questions or read them out for Tarun. Actually, on that, there is a question that's come in to say, thanks so much for your talk. You hadn't mentioned community engagement, but you have now in your response. But do you have any comments about how you did do that, and what you might do differently next time?
We did because in the Territory there is there are enormous separations you get in bigger states between public health and primary health care. It's all kind of one, okay? Because first of all, people are really, really sick, okay? That's the and particularly Aboriginal people, are really, really sick, and there's high levels of hospitalisation, high levels of presentation to primary care, and at that time a real deficit in terms of the provision of primary health care in the Territory. So you can't afford to have this kind of mainstream distinction between public health and primary health care, because you just have this, they're integrally linked at a community level. So when I'm sitting, and I was an outreach physician for 8 years as part of this, when I was community physician, so I used to go and do clinics in all these kind of remote top-end communities. And you're dealing with all of the diseases, and you're dealing with the links between what the Aboriginal workers are doing at a community level and what the messages are around diabetes prevention, etc. It's all mixed, because the people with illness have got families who are at risk, and pretty much the whole community is at risk as well. And the places where the public health and primary care are being delivered is the same place. It's the community health centre, it's through the local council. I'm not sure if I'm explaining that well, but it's a much more combined workforce a combined set of challenges, and you can't neatly separate the prevention from the early detection from the management, because they're all happening to the same people and the same families and communities. And also the resourcing, even though it was not sufficient, it was still easier to get resources and find arguments to get Commonwealth investment into primary care, because that's what Commonwealth does. It funds primary care and Aboriginal community-controlled health services, and the territory, funds of its own and relies heavily on Commonwealth grants. And so, in terms of strategy to get investment in chronic disease, the strategy was to make this more of a primary healthcare issue in the first instance, and to look and see whether we can get Medicare funding to employ chronic disease coordinators or child health nurses, and all of that kind of stuff happened. And then those same people, once you've got the workforce, can work on some of the prevention and other bits as well as delivering the primary care. And there's a network of both government-run and Aboriginal community-controlled health services across the territory, and they're all kind of joined up through primary care. And in my work with government, it didn't matter to me whether I was working in a Aboriginal community-controlled health clinic or a government clinic. We just had a system whereby we'd applied the resources across all of the centres. And so I spent a lot of time working in community-controlled organisations as a clinician, paid by government, so it didn't matter. But at a system or organisational level, there was still a bit of a separation between government, community-controlled sector, and possibly we didn't spend enough time dealing with those issues at the time. We just decided to try and get going on this, to get some investment into primary care, and kind of let the other stuff work its way through. Frankly, we didn't have a lot of time, because if we had not delivered a strategy, there would be nothing to go back to Treasury with around renal dialysis. Now, clearly, there had to be also then funding for more renal dialysis beds, etc. But the government was more willing to do that if they thought that there was a process to prevent the rise in renal dialysis over time, which was the chronic disease strategy. So we had to get back, and we had to do something. Government can't not act. But there's a trade-off in terms of time, consultation.
Great, thank you. Catherine, I'm sure you've got lots of questions as well, so I'll share the space. So hand over to you and let you ask something as well.
Thanks, Lucy, and thanks, Tarun. That was a really interesting presentation. It sounds like the strategy had a lot of success in that primary healthcare sector, but you alluded before about you were a little disappointed with the lack of action outside of the health sector. And when we think of preventing chronic disease and NCDs, it is often those structural and social determinants of health that make the big impacts. Was that, could you tell us a little more about, were those aspects covered? Why weren't they taken up, and what do you think needs to happen to make those changes occur?
So we're in the arena, thanks Catherine, we're in the arena of social determinants of health, as people understand it. And we totally understood that when we wrote the strategy. And we look at the evidence base, it's heavily focused on social determinants of health. So it's not as if we didn't recognise the determinants and their importance to chronic disease. But when we went back, last year and did the review, this is early last year, there's always the difficulty about getting engagement from health to other sectors and getting engagement from government health to community control. Now, those things have always been there, and people do work collaboratively together, and there are forums and there are ways to bring the sectors together, but it's never easy. And part of it is to work out, and I don't think any state has, we all have tractable social issues which we know are impinging health, whether it's on education or employment or housing. These are perennial issues which I suppose explains a bit why organisations like the Public Health Association have to work with other organisations, whether it's the Council of Social Services or whatever it is. You know, Public Health Association is never able to be the one best advocate for those social determinants, but we all understand them and we can partner with others. So it's about understanding the nature of the partnerships you have to put together to help drive change in these other very, very important areas, though we're not the experts on them. You know, I'm not an expert on housing or education, I'm just an expert on health. So it's difficult to take the lead on those other areas. But the question is, how do we support those other areas? But the other question is, how do you construct government systems that actually join this stuff up properly and you have the right kind of conversation? Because it's very easy to create government committees and whole of government committees, but people will still act with their own departments, you know, interests, you know, and I'm not being cynical here. That's kind of normal. We all come to a table with, and we have to kind of act in our own interest. So I would always say with intersectional collaboration, so that's where we're kind of getting to. I remember, I think we referenced some stuff on intersectional collaboration in those early documents. It's not about asking other people to do things for you. I would say if you're doing that, that's like charity. That's not it. It's about creating the argument that if we all do this, we will all meet our objectives and objectives better. So if you're from education, there's a reason I'm asking you to talk about health and chronic disease, because it's going to, in some way, help you achieve what you want to achieve in education. But part of the challenge there is not just jumping on what's good for health, it's trying to understand what those other people are coming to the table with and what their agendas are. So we can have a combined conversation about what each of us can do, which will create both a whole of government's objectives or meet each other's objectives. So I'm not quite sure if that makes clear, but I think a lot of the I think health sometimes makes the biggest mistake possible, which is to assume that health is the only thing that counts. I made that mistake in the Aboriginal setting. I remember when I started on as a researcher. I was at a conference, a public health association conference in Perth, and I had a chat with Jeannie Devitt, who was a researcher on health and education and other things and land stuff. And she said to me, Tarun, I've been doing this work on health and land issues, other things, and guess what? Guess what's most important to them? And I said, as a young researcher, oh, health, of course. And she laughed. She goes, of course not. It's land, right? So it was just my immediate reaction was to assume that health was what drives people. And she says, people aren't that interested in health. They're interested in this other stuff.
Yes.
Once you do health for a different reason than where you get to health from. And it's been part of the reason I've never particularly been a supporter, and I expect the comments to fly back through the chat function at this point, so just be kind to me. I've never been a great supporter of health and all policy. But there's some point to me which says health is the most important thing and we're going to tell you what to do to improve health. And I've always found that not a particularly effective way to engage others in other departments. And so I've not used that framing. Of course I understand about social and commercial determinants, health and the importance of other sectors, but A, I'm going to recognise that I don't know as much about those other sectors as they do. And B, that not everyone thinks health is the only thing that counts. And C, I don't want to start with a position which kind of assumes a kind of a slight health imperialism, for want of a better term. Okay,
yes,
now send the hate mail through chat. I'll deal with it.
No, I've definitely heard other people talking about being cautious about the health imperialism So I know exactly what you're saying. And in fact, you're touching on one of my favorite topics, which is the idea of really it's about the co-benefits of what we do and looking for the common agendas, because there are so many shared agendas. It's just we need to be able to articulate those. And it's a nice segue into asking you about your work in the climate change and health space, because you know, you've worked in chronic disease, you've worked in the response to COVID, and you've also obviously done some really significant work with the WA inquiry in the climate and health space. So I wonder if you could just tell us a bit about how you got into that and why you got into that, and yeah, maybe touch on this idea of co-benefits if it's relevant.
Yeah, it is. Thank you. I stepped down as Chief Health Officer in the middle of 2018 after 10 years in WA, and I was really looking to do other things and just because, you know, I just wanted to keep challenging myself really. And so this was the ideal job that came up, I have to say, which was to do a year-long inquiry under the Public Health Act into the impacts of climate change on health. And it was such an enormous privilege to be given that time. I don't think anyone else will ever be able, you know, given that opportunity again, because, you know, it's such a significant thing. I think hopefully there'll be some shorter bursts of this. Now, why was that asked for? We'd had a sustainable health review with a couple of years up until 2018, 2019, which was like a 1 in 20 year review of the health system. And the previous review in the early 2000s in WA had focused on building up, or ended up, even though it talked about prevention, ended up being the blueprint for building a whole lot of, you know, really great hospitals and new facilities across the state, and dealing with some of those issues at the time when there was a booming economy and, you know, plenty of money in WA to build these facilities. But in the mid 2010s, it was clearly that was a different phase we were in. We needed to look beyond the hospitals in terms of what was sustainable, and there was a gradual cutting back on the rate of growth in health. Remember, at points in the early 2010s, health was growing at 7-8% a year in terms of expenditure, and it was, you know, unsustainable from a whole of government perspective. And so the Sustainable Health Review was looking at, was on the back of probably a successful capping of that rise, even though the health expenditure continues to rise and now rises, you know, a couple of percent a year rather than 6, 7, 8%. But also then saying, how can you change your models of care, etc., to make it more sustainable for the long term? So the initial framing of the Sustainable Health Review was around financial sustainability models of care. And of course also population well-being, but the environmental sustainability wasn't a strong component of the word sustainable in that framing of it, but got introduced through stakeholders actively advocating for it, saying, you know, we also have to look at the environmental elements of sustainability. And so the Sustainable Health Review, led by Robin Kirk, created some opportunities to have some forums around environmental sustainability based on feedback from consumers and you know, various groups. And part of their recommendations were to look at this further and to reduce emissions and waste in the health sector as part of that sustainability journey, to report on emissions regularly, and to hold a climate health inquiry to tease out the actual impacts on physical and mental health in Western Australia, and to create a path forward similar to the path forward the Sustainable Health Review had created for, you know, other parts of the health system. So that was accepted in early 2000. Actually said, well, we'll do this. This is something we can do. We'll commission an inquiry under the Public Health Act. And the then Chief Health Officer, Andy Robertson, asked me to come and do this inquiry for them. And I was, you know, delighted to do that. And I just paid tribute to the team we put together. And I wasn't you know, I'd done as head of public health, you know, I'd obviously had, you know, a fair bit to do with environmental health over the years, and that had been kind of part of my portfolio, you know, for 15 years or so. But I wasn't, and in no way considered myself an environmental climate expert. And that, again, just like having no resources, gives you a strength. You don't have to pretend, right? You don't have to pretend that you're the expert. What you do is you get all these other incredible people in, and you listen to them, and you try and synthesize what they're saying. And it's like the distinction. My supervisor, has been very influential to me, was John Matthews, my PhD supervisor in Menzies, who's now an emeritus at the University of Melbourne. And I think it was him who told me the difference between research and scholarship. And research is, you know, the generation of new knowledge. But scholarship is just as important. It's a traditional university academic function, which is you're a scholar. You pull together all this information and you synthesize it. And that act of synthesis is a kind of typical kind of humanities type discipline type thing. You make sense of something. And I think I'm a better scholar than I am a researcher. You know, because I struggle, I don't see myself. I'm always trying to understand what the hell people are talking about. Abstract stuff, kind of, I struggle with. I don't know what it means in terms of this acting in the world. What does that mean I should do? And so if I'm struggling to understand something, I'm actually doing an act of scholarship. And what we set the climate health inquiry up was a story that sits between all of the expert inputs and all of the stories we heard through the inquiry process. So this goes back to what we talked about offline, Lucy, which is this process of change. So if you think about climate, there's a whole lot of climate science. There's a whole lot of people who can tell you about the impacts on health. But then we can also add up all of the stories we heard through the public forums and the submissions and the 35 public hearings we had. This is a wealth of information which contributes to this evidence for action, if you like, but it's experience for action or evidence for action or stories for action. And then what the climate inquiry does is create a story in the middle then, which is a high-level story about all of that we've heard. So the inquiry report is written to be read by people who don't know about this. So I wrote it for myself, not knowing about the subject, and you know, trying to explain the climate science for people like me who are not experts, who try and create a clear description of what we were being told, and then the first 5 chapters, and a description of the health system, a description of the context, and then the last 5 chapters are about how we could change, and in a very practical sense. And there's only 10 recommendations, 10 findings and 10 recommendations, trying to keep it simple. So my rule of 3 changed to a rule of 10, but I think given the amount of material we had, I could give myself 10 findings and 10 recommendations for a year-long inquiry. And it's pretty simple. So if anyone hasn't seen it, if you just Google Climate Health WA inquiry, just read the exec summary at the beginning, which is a summary of the chapters. It's 3 pages, and it tells the story chapter by chapter of the report. And so you just have to read those 10 paragraphs, which are the summaries of the chapters, and you get the whole inquiry in miniature. And going back to humanities, Lucy, the reason I structured it that way was because I love reading as a kind of young person Victorian novels where they have at the front the description of what happens in each chapter, where the hero, you know, finds his true love and goes off and does something, and you can kind of have this little précis of what's going to come in the chapter. And so that's how that's written, as a little kind of story within a story about what that thing is. Now, the other thing is that the whole process creates partnerships. So by hearing people's stories, by putting them on record, the message to government is you're not in this alone. There's a clear role for you, but here's all these other people who will support you to bring about change. And we were able to get those commitments, if you like, onto paper. And the Next part, after you've created the story in the middle, is to create the new partnerships for change. And post-inquiry, the report was released in November last year, at the same week as the state climate policy, which accepted many of the kind of findings in our report. What I've been doing very actively is working to just stimulate those partnerships and suggestions about how people could work together. It's really about creating new partnerships, but also people want to contribute. But not everyone can do everything, right? You just need to know your role and how much time you've got and what you can contribute. And often it's not about inventing new stuff or knowing new stuff. It's just about supporting someone else to do something, or creating a new sense of possibility, or finding out who knows and are the leaders in your organisation. And often they are young people. But this is also a message for older people, is that people at my end of the career, about maybe you can just get out of the way, or you can support someone else to do something, or you can cover their back. Use your reputational capital to cover someone else, to go, you know what, I trust you, get on with it, and I'll cover you. And it was kind of the same thing that Shirley Hendy did for us as a group when she was Chief Health Officer. Back in the late 90s, she gave carriage of this chronic disease strategy to a group of fairly young people, and then covered them. And credit to her.
Yeah, I love that. I love the fact that you're sort of emphasizing the importance of narratives and stories. I listened to your wonderful podcast that you did with the University of Western Australia, The Meaning of Health. So if anyone hasn't heard that, you should really follow that up and have a listen. And I really liked at the end the way you talked about the 3 elements of creating change. Starting with the scientific evidence and the data and the knowledge, and then the creating and telling the stories about the issue, and then the action, engaging the partnerships and networks to implement action. And I think we often forget the second one, and I think it's something that we're really trying to sort of work on as a team here at the Prevention Centre, because the importance of those shared narratives, the importance of that in creating the stories for prevention and about prevention. But it's incredibly challenging, and I wonder if you could sort of elaborate a bit on what makes an engaging and compelling story. How do we talk about prevention in a way? Because preventing what does that even mean? So how do you tell the story of prevention?
I think there's any number of ways you could do it. I mean, I've been struck, I'm not a very visual person. I'm more a words person. People are really visual. You can draw something. So I was at a conference at the Aboriginal Health Council WA conference a couple of weeks ago, talking about this climate inquiry, and they had a person there who drew each presentation as you gave it, and gives you a picture with the main points straight after the presentation, and they're incredible pictures, right? And it's the best summary of the talk you've ever done, and it's also meaningful because it captures it. So there are people who can do things visually. In writing grants, John Matthews always used to try and make me do flowcharts that put everything on a page. I hated it, really hated it. John loved it, and his number of boxes and stuff was just, used to do my head in. But he was brilliant at it. So I struggle with my, visualization of how all of this fitted together. So pictures can help. Metaphors can help. And I'll give you one in a second. And, you think about, kind of religious and parables, and, there are things that inspire and drive people that are ways of speaking or showing. And you think about, I went to this extraordinary exhibition around the Seven Sisters, which is Aboriginal, stories around the Seven Sisters, which is at the gallery of the new museum of WA last week. I tweeted about it because it's so meaningful. It's across 3 different states. It's a national exhibition, and it just blows your mind in terms of the understandings of, the understandings of land and meaning across this continent over generations. And if it doesn't make you think and reevaluate your sense of what the hell we are and who we are, want to become, and our sense of identity as a nation, it's you know, I'd say to you, it's more meaningful than any public health thing you're going to read. So just go and do that, and then think about what it means for your work. And it had that kind of impact on me. So in terms of metaphors, the one I've been struggling since the inquiry ended to find ways to convince people to act, right? And so I've gone for this race metaphor. And the race metaphor is something like this. It's a 100-meter race. The health sector is closer to the starting line than the finishing line. It's barely off the starting line in terms of what we have to do to get our own house in order. And we're barely moving. You know, there's some movement, but we're walking slowly, if you like. But there are people who are further ahead and who are running. Now, what I think the health sector wants to do, or sometimes seems to me wants to do, is argue about how fast we're going, where the starting line is, where the finishing line is, whether we are 5 yards or 10 yards away from the starting line, what the conditions on the track are, what are the rules, you know, whether the weather's good enough. It's all an excuse to not act. Okay, if we're standing, if you see a kid standing at the beginning of the 100-meter race and they're not running, you just say, run, come on, just get going. Stop arguing and just run. And that's how I feel the health sector is. We can find any number of excuses not to run, including, well, you know, what's our targets? Is it 100 or is it 105 meters? I can't quite see it. The fact is you're never going to see it because you're running so slowly that it's getting further and further away, and people are just running away from you while you complain. Now, that's a bit harsh. So the way I try to frame that is, you know, the hare and the tortoise. I went back to Aesop and said, well, what are we? And I said, we're not even the tortoise. You know, we're not making slow and steady progress. So we're not the tortoise. So then, are we the hare? We like to think we're the hare. But if we are, we've just woken up as a health sector in climate change, in terms of climate action. And the hare who's just woken up is not a very effective advocate. So we're great at advocating, you know, health and all policies, this, and, you know, what every other sector should do, education should do this, and da, da, da. We're good at that. We talk about social determinants, we do this. In the climate field, what credibility do we have if we're not acting to reduce emissions in our own sector? I mean, I'm sorry, you know, you can't just be expected to be, you know, we're here to help people if you're not doing the stuff you need to be doing around stuff. Now, this is a hard message. I tend to say it too harshly. I'm trying to wind myself back, find nice metaphors, be a bit more diplomatic. And this is a lot of what I'm doing at the moment, is challenging professional groups about their power and what they can do with that power, both at an organisational and individual level.
Great. Catherine, over to you.
And this question may lead on quite nicely, I think, from what you were just talking about, Tarun, and it also builds on a question that we got from Ellie Howes. With government inquiries, and it's fantastic that WA did that climate health inquiry, there's often a lot of recommendations that come out of those, but then few are implemented. Have many been adopted from the report that you wrote? And then two parts to this question is, how do you get governments moving from inquiries and strategies into action and change?
Great question. So when I was doing the inquiry, I talked to the Director General of Health, who was my old boss, obviously, and he said to me, Tarun, don't give us, you know, hundreds of recommendations. And I thought it was fair, because I've been on the other end of inquiries as a senior exec in health, and you end up just reporting on, you know, 50 recommendations over here, another 40 over there, and 70 over here, and it becomes just a process of ticking boxes in terms of responding to recommendations, some of which become less relevant over time. So I think the first thing is to make sure that your recommendations are few and important. The other is to phase them so they have some recommendations come before others. And really, I boiled my 10 recommendations down to one. Our first recommendation was to establish a sustainable development unit in the Department of Health, which would then act as the nidus, the catalyst for all these other changes and the other 9 recommendations. And it's a bit, again, like saying you can just start small and then lever off all this other energy in the system. But without that catalyst, without that small leverage, you won't be able to get going fast enough. So the report was accepted in principle, all recommendations, all 10 recommendations, but it was released in the same week as the state climate policy. And there were a couple of points. One was a couple of our recommendations actually got incorporated into the state climate policy, which was to establish a sustainable development unit in health, but also look at policy and procurement reforms across health. So there's 2 recommendations in the state climate policy, and the health department will come back with an implementation plan around the 10 recommendations. That's what the minister's asked for. And he's called it a blueprint for what has to happen, in terms of environmental sustainability. In addition, there are follow-up recommendations from the Sustainable Health Review, which is still there. And one of them is to commence baseline emissions reporting. And that actually was meant to start mid last year. It hasn't started yet now, COVID or whatever. To go to your last question, some of the work I'm doing is to say, you don't have to advocate for anything new. Just find out what government has promised to do and just check back with them about whether they've done it. That's the most fundamental part of advocacy, not about new stuff. And we all get captured by wanting to create the new stuff. But actually there's existing things that just need to be followed through. And the most powerful advocacy is not using your own word, but using other people's words. So, if I want Lucy to change, I say, Lucy, you said, last year that you would do this. And what's even more powerful is that we've got captured in the climate inquiry 35 formal hearings where the chairs, chief executives, or the health service board, all these range of other organisations have come and talked to our inquiry about what they will do themselves. Now, most of them have already put in written submissions, which is the usual stuff. But the power of the verbal, you actually said this. It's transcripted. You can go back and listen to it. No, I don't expect anyone to listen to 30 minutes. But if you were a employee of an organisation that had made a submission, or your CE or chair had come to the inquiry, you can just go to our website and you can find what they actually said. And then you can write to them and go, it's really great that our organisation committed to this, have we done it? There's an endless amount of kind of small advocacy you can do by using what people have already committed to.
Fantastic. Tarun, and you've worked, in government, and you've worked outside of government, and you've said that you loved being a public servant. And I wonder if you could reflect on the difference between sort of trying to effect change from within government and working outside of government. What is the difference? And also, what's the role of needing to understand politics? How do you balance science and politics in the work that you do?
I think Mike Daub, who people will know very well, is probably the best person who's talked and written about the roles people have inside and outside government. And I've learned a lot from Mike, who really does understand insider, outsider roles. People have to realise that we all have different roles and we all have certain opportunities and constraints that apply, whether you're in academia or in government or in a non-government organisation or a private citizen or whatever it is. There are certain constraints that apply. So, if I was to ask you something about, your university, Lucy, there'd be some constraints in which you couldn't, even if you knew something, you couldn't speak about it without breaching some confidentiality or some other important ethical process. Similarly with government and similarly with advocates. So, and I don't think any less of you because you can't do that. And I understand how you are constrained, but I also understand you've got a particular opportunity as an academic. You can understand that I've got a particular opportunity as working in government, and we can work together on this. And we also, in a democratic society, can understand that we can understand each other's roles, and not only understand our own roles, we also understand how the whole system works, in that this will become public, other people will be able to then commentate in the media, you as an academic will be able to comment where I couldn't comment. And so part of what I've always focused on is transparency. You don't need me to say all the things that an advocate needs to say, but what you need from government is transparency. And then other people can respond with their different hats on. And so there we start to get to the politics. The politics is understanding how the system works. And I'm not, as a person in government, trying to develop a reputation for being the kind of, most right-on, advocate, because that's not my role. Now maybe as president of the Public Health Association, I move on. I do different things, but at the time I'm in government. But the biggest mistake people make is assuming that all people in government, you can't trust them, they're all bureaucrats who come wasting your time. That is the most unsophisticated and silliest and most self-defeating thing you can. What you're doing is you're mistaking your friends for your enemies. There are people who are absolutely as committed to you as to getting these outcomes, but they have to do it in a different way, and you have to understand that. And you have to understand that they understand that. And they're actually giving you an opportunity, should you wish not to kill them, to do that. But they can't go beyond what they can do, but they can act in an ethical and transparent way, which then allows this conversation to develop in a particular way. And there are a lot of conversations that happen between senior people who understand these things, who can pick up a phone and have, an off-the-record conversation. And people understand each other's roles. And Mike is someone who's been a Director General of Health, who's been President of the Public Health Association, has had lots of hats over the years, who's done amazing work in, not just tobacco advocacy, but a whole range of public health advocacy. Mike's the best person to talk about that, and there are some very, very skilled people. And it becomes not wanting to be having the most progressive position on something. It's about actually wanting change. I don't care if I'm not liked. I don't care if people don't know what I did. I have to live with myself to know that I did the right thing in my own sphere. I don't have to have done everyone else's thing. That's not my need. So, and there's a lot of very, very good people who are working quietly, who just get on and do the right thing. So whether that's in local government or in non-government organisations, who never get the kudos, etc. But they're comfortable knowing that they've done the right thing by their community over their lives. And equally, there's lots of people in government who are just doing that, even in kind of senior positions, quietly making things more possible for others. Now, if you don't think that's the case, you can call that out, but don't assume that people aren't trying to do the right thing. Okay, public service is still the public service. It still serves politicians of both sides of Parliament, of all political parties. It still has a job to advise governments about government policy and to implement government policy, regardless of which side of politics that's in. And people take their ethical duties very, very seriously. And that's a positive that you can work with. Finally, I'll say, so I wanted to give a shout out to people who write about policy, who understand policy. And it's surprisingly rare, because often I will pick up kind of academic books on policy which don't feel like they know what it's like to work inside government. And the kind of flexibility and the creativity and the greyness of it, but it's you know, it's really interesting. The person who writes the best about policy is Jenny Lewis from the University of Melbourne. I'm not sure, I haven't read all of Jenny's stuff, but I remember her book on health policy and politics. I think it was called 2005. But the subtitle was something around ideas, networks, and power. She's the only person who talks about the power of ideas in public policy. And when I go back to describing that chronic disease stuff, you can see that there was a strength of an idea around the integrated approach to chronic disease that allowed a momentum to build around chronic disease action in the territory. There was also a whole series of power relationships that we do have to understand and shift subtly, whether we're dealing with chronic disease or climate or COVID or whatever it is, which deals with the inequity, power inequity, societal issues. And then the power of networks. Part of the power of changing is creating new partnerships, understanding your networks, building networks between inside and outside government. All of these things come together when you're thinking about change. So I wanted to shout out, Jenny doesn't even know I'm a big fan. I haven't talked to her in, I don't know, 15, 20 years, but I just keep her book there. And I just kind of go back to it because I feel like she sees us in government, if you know what I mean. She sees what's happening actually, as opposed to writing something which is, very, very rational. At least, I call it the rationality trap. Most rationality can only take you so far. And, endlessly creating gold and target performance indicators, etc., only take you so far and can actually be a trap. And there's a lot more to public policy and public change. Of course, evidence and rationality is a good starting point. I'm not arguing against that, but there's also other stuff you need to add on beyond that, which I think Jenny gets. It's about how a knowledge industry works and how we as social beings interact with each other inside these complex systems.
Great recommendation. I know what our next reading is going to be. That's wonderful. And I think one of the most enjoyable aspects of working with the Prevention Centre is that creative intersection between our policy partners and the researchers and the practitioners. So that's great. Catherine, I'll pass to you.
Yeah, I just wanted to know, in terms of partnerships and collaborating, how important have NGOs and civil society been for you in your role in progressing change?
Very important, so particularly that early experience in the NT, because everyone's based in Darwin, you can actually just within a few weeks go around and just talk to everyone, right? So that's one of the advantages about being in a small place. And the same applies in regional and rural Australia as well. You can do more sometimes in regional and rural Australia because you can just go and talk to everyone. You can get a really good sense of people's stories, about what the potential is, who are the strengths in the community, and what are the strengths in the community, etc. And so each of those NGOs is not a big player in and of itself in a place like the Territory. And so they actually saw a benefit in combining together and they created a new alliance called the Chronic Disease Alliance, which was an alliance of NGOs in the Territory in order to engage with the Chronic Disease Network. And so I got to know everyone very personally, and there were things that the NGOs can do the government can't, right? So people with Diabetes Association obviously has got way better connections with people with diabetes, and so it can get that message out around whatever it is, and find and create focus groups or do things. We did some work with around cultural and linguistic diverse groups in the Territory in the late 90s and their experiences with diabetes services, for example. But the best example of how partnerships can trigger change was having created the Chronic Disease Alliance. Diabetes Australia, I think, were probably the the most involved of the NGOs and had a particularly good relationship with their CEO and Kemp. And a couple of years later, one of the best eyes in chronic disease that we had identified was cardiac rehabilitation, and it wasn't being done. And a tender was put out for some cardiac rehab services in the NT by the Northern Territory government. And Diabetes Australia actually tendered for and won that contract. And I just think that without that whole notion of we're part of chronic disease, we can, we don't have to see ourselves as diabetes only. They ended up, understanding other people and being able to put together a proposal to deliver cardiac rehabilitation services. It was kind of one of those things that only happens in the territory in a small place. I think it's harder. When I came to Western Australia in 2008, one of the things you miss is that ability to just understand and interact with people, in that small town kind of context. And a lot of the NGOs here were much bigger. We were all with their own bases, and I wasn't involved in that chronic disease work specifically. And each of them makes its own contribution, but not in the same way you can join up. And so bigger places have particular advantages. So one of the advantages was coming to WA is that, in pretty much every specialty area, there was an expert I could call in WA. And that's enormously beneficial as a chief health officer, in that I've just got a whole load of people who I can ring for a bit of advice. That wasn't the case in the territory. We were all kind of, playing it by ear a bit, and I'd have connections I could call in different states and territories, but they're not all on tap for you in the territory. So the subspecialisation is clearly a benefit in some areas, but it also drives against a little bit the integration. So maybe the integrated model we set up in the territory is less possible in WA. Mm-hmm. And when I look at Sydney, or when I look at New South Wales or Victoria, I'm very happy to WA, because I couldn't grasp that whole system even to the extent I can grasp it in WA. So at every, you might have more resources in your big states, but there are things we can do in WA that aren't possible in those big states, and there's things that can be done in the territory that aren't possible in WA. And we have to just, what I say is that no one's on the center, no one's on the periphery of our lives. We're all at the center of our own lives. So this whole notion of urban centres is a kind of a myth. It's like person at the centre of Western Australia. Wherever you're living is the centre of your life and the centre of Western Australia for you. And if you're kind of the centre, you don't have to have a kind of false idea that you're living somewhere in the periphery. You're living in the centre of your life. And this is your community. You can understand more of your community. And then you bring things to Kununurra from your connections and your networks to affect change. And guess what? If you do amazing things in Kununurra, you create these new models of care. You create this new way of seeing something, which then other people go, wow, that was good. Can we do that in the metro area? So forget the idea of centre and periphery. Just understand that you're at the centre and that we have to pull from everywhere else. And I think COVID's given us a bit of that sense as well. I always used to feel a little bit, as a usual global citizen type, that you live a little bit on the edge in Perth, a little bit away from the action, right? And, I've got interest in international health and other things. You feel a little bit removed here, and we're glad we're in the time zone of GMT +8, and it gives us this view of Asia, and we're in the same time zone as Singapore, and up into China. That's good. But until COVID comes along, you don't realise that everyone has to live somewhere. We all have to be somewhere in the world, and then at the moment we've got to stay there. But it doesn't actually matter where you're living. We can all contribute to a whole range of conversations nationally and internationally from wherever we are. And that can be rural or regional Australia as much as metro Australia.
Mm-hmm. So this builds on a bit on the idea of the role of civil society, because you've worked in medicine and research and then in government, and After retiring from the public service, you've decided to be the president of the Public Health Association of Australia. So why did you, I mean, you obviously you must have limited time. You've got so many roles. Why did you decide that was an important thing to do, and what is it that you're hoping to achieve? And what role do you think PHAA has in progressing the prevention agenda?
So I was exposed to PHAA in my first year in the Territory in 1991, and there was a conference. The national conference was in Alice Springs, and John sent a number of us from Menzies and Darwin down to Alice Springs to attend the conference and it was so much fun. I mean, and you know, I was your usual, you know, young, left radical PhD student, and I found a whole lot of other friends of the same bent, all who cared about public health and Aboriginal health and, you know, social determinants and all of the other stuff. But it was fun. It was a community that I could engage with, and it was multidisciplinary. And committees and various SIGs and other things, special interest groups, and ended up being the program chair for the conference in Darwin in 1999. So it's a community with a lot of diversity, a lot of multidisciplinary input. And then I took a little bit of a break because I was a bit exhausted and other things to do, and I kind of came back to PHAA a few years later and have been strongly involved in the WA branch in the last 10 years. I just think there's no other body like PHAA in terms of representing the totality of the public health workforce. And it continues to have this strong national branch and special interest group focus. You can kind of pick and choose where you want to put your time. There's all volunteer work in Canberra. So it's dynamic, it's fun, you can find ways to contribute to network, you learn a lot from people, you get challenged, and it also keeps you in touch, you know, with younger people coming up through public health. It's great, you know. So I don't really do anything to work with people and to see if you can affect changes. I think PHAA has really strong policy settings, you know, policy work that it does, which contributes to advocacy. So it has had a really strong focus on policy, which comes through in all of its deliberations up until national conference every year. You know, you can build different policy process. So it's also really good for your career because you meet people and you understand how policy starts to go into action. That's on the one hand, all the positives about PHAA. There is another side, which is a critique of medical dominance. And so I'm going to mention the other book, which I want to point people to, which was published almost 40 years ago, which has possibly been the most influential book I ever read. And it's by Evan Willis, who I think is still around, Professor of Sociology, called Medical Dominance. I ordered a copy of, you know, one of those book sites recently, and I just got it and reread a chapter which I hadn't read for years, literally 30 years. So it's a book I haven't gone back to, but it influenced me. And it's a chapter on the influence of the medical profession in Australia. And the chapter is about the subordination of midwifery in Australia. And so Professor Willis writes about these different ways the medical profession attains dominance within the wider society. But it was the chapter on midwifery that I remember, and it's because the point is made that the medical profession has been strong in Australia and dominant since 1910. So this is not a new phenomenon. There is entrenched dominance of the medical profession, which he traces back in the history of public health in Australia to the early 1900s. So what you see today in 2020 is really a long-standing pattern of entrenched dominance of the medical profession. Now, I'm a medical professional, and there's great colleagues, etc. But I have to recognise where my profession is. And so, yes, I'm part of the Australasian Faculty of Public Health Medicine. I'm strongly encourage people to use their organisational power for good. But I've also been a bit reflective that I didn't just want to contribute to the continuing dominance of medicine over other parts of public health. And in order to do that, the choice I've made is to put my voluntary energy much more into the Public Health Association of Australia than into the medical professional colleges, though I do bits and pieces for them. So I'm not sure if that answers your question, Lucy, but that's why I care about the Public Health Association. I'm not having a go at those others. I just think it's important to understand that history and politics and that reflection on our power and privilege personally and professionally is important when you're making your choices about what you want to do with your life and time.
Well, I think that's a really wonderful place to finish up, because I can't believe we've been talking for nearly an hour and a half, but we've only got a couple of minutes to go. So, Tarun, thank you so much. It's been such an engaging and fascinating conversation. I wish we could talk for another hour and a half. And like I said, those of you who really enjoyed this, do go and listen to the podcast, The Meaning of Health, where I think it was episode 37 that you recorded with them earlier this year. And from what I understand, they enjoyed it so much that they're having you back to talk specifically about the Climate and Health Inquiry. I also just want to say thank you so much, Katrin, for joining us for this conversation. Thank the coordinating centre team here, and to Karen from the Sachs Institute for organising all the logistics, and particularly to our audience. So thank you so much for joining us today, and for those who are listening later to the recording. We will be sharing the recording on our website, so with registered participants, but also just putting it up on the website for others. And of course, I also have to say, and I want to say that all of our news and events are publicised through the Chronicle newsletter. So if you haven't yet subscribed, do go to our website and subscribe. But thank you so much, Tarun. It's been really wonderful, and I really appreciate it. So thank you for your generosity of time.
Thanks, Lucy. Thanks, Catherine. Thanks, everyone.
Thank you so much. Bye.